Okay, so I think that we can start this session. It's full packed, so there is a lot of enthusiasm regarding this topic. I mean, after all the trials that have been published, clearly this is a hot topic and where the interventional cardiology has a lot of interest in. So will be a cardiogenic shock and high-risk intervention with percutaneous mechanical circulatory support and new evidence and insights. Clearly, this was sponsored by Johnson & Johnson MedTech Heart Recovery Abiomed, and I'm chairing this session. The discussant will be Mirvat Alasnag. Mirvat, please take also the stage. And Vasileios Panoulaos and Giuseppe Tarantini that will join us soon. Which are our objectives is to learn the latest data on microaxial flow pump, Impella, in cardiogenic shock, to learn how to improve survival of cardiogenic shock patient, and to see latest data and EAPCI consensus on high-risk PCI in patient unsuitable for surgery. So let's move to the first speaker, which is Mirvat Alasnag, that will talk about high-risk percutaneous coronary intervention in patients with reduced left ventricular ejection fraction. So please, Mirvat.
Good afternoon, everyone. So can we get to our session? It seems the session here is the previous one.
So you have to change the session. This is the prior one, or it's whatever it is. Okay, that's the correct one. I figured it out, okay. I don't have any relevant conflicts of interest. So how should we manage symptomatic patients with LV dysfunction, impaired LV function? So one, we know that CABG is recommended over optimal medical therapy in patients with reduced LV function based on a lot of historic data, starting from the CAST trial to the STITCH 10-year results that actually showed a mortality benefit. But we're interventional cardiologists. This is an interventional meeting. We need to ask the obvious question, CABG versus PCI trials. One, we know that they excluded patients with severely reduced LV dysfunction or those who were deemed inoperable. So actually, the patients who were enrolled in the majority of the trials were patients who were suitable for bypass grafting. The next question that comes up is optimal medical therapy versus PCI. And the plethora of data to date has actually demonstrated no additional benefit in terms of mortality with PCI. The most important was the revived BCIS-2 trial that, however, does not really represent a subset of patients that we will be discussing this afternoon, namely patients who are symptomatic, patients who present with acute coronary syndrome, patients with recurrent hospitalizations. Actually, these were exclusion criteria for the revived trial. But when we look at a lot of the real-world data, a lot of the observational data and registry data, it suggests that PCI with modern drug-eluting stents is an alternative to CABG, and that we have to recognize that 50% of the patients with LV dysfunction do undergo revascularization, meaning PCI. So what are the options for the patients who are surgical turndowns? Reminder that these are patients that were not represented in the trials that shaped our current guidelines, but we see them in practice. I practice in the Middle East, where impaired glucose tolerance and diabetes accounts for about 40 to 50% of the patients that we see in our catheterization laboratories. This is an example of a patient who had recurrent admissions with pulmonary edema. And as you can see, just look at that LAD, very classic of diabetic patients, not attractive to the surgeons, was a surgical turndown. Nevertheless, the symptoms were very impressive. You have an ostial circumflex, you have LAD disease that's diffuse, equivalent of a distal left main really. And when you look at this here, this is the right coronary artery, not impressive at all. Look at the size of the coronary artery, irrespective of the ostial disease compared with the guide catheter. So again, these are patients that we probably, as technologies improve, drug-coated balloons, etc., we may be able to offer them something. So this particular patient, it was a dilemma to get him out of the hospital. The target was to survive the hospitalization, and so we had to revascularize him. So we went ahead, treated from the left main to the circumflex, and then did a tap stenting into the LAD, and you can see the steps. It's not the purpose of this discussion. Nevertheless, we were able, with mechanical circulatory support, to do the steps appropriately, do our POT, do our kissing inflations, and so on. And this was the final result. You still see a very diffusely diseased apical LAD, but this is the echocardiogram after discharge and 2 months later. Again, there is LV dysfunction, but that wasn't the purpose. The purpose was to get this patient out of the hospital. So how do we define high-risk PCI? We need to standardize it, and unfortunately, we haven't. There's the latest EAPCI consensus document that was actually released that looked into all these parameters. One is we're looking at, for the majority of these patients, elective coronary indication rather than emergencies and STEMIs. The first part of it is looking at the patient himself or herself and looking at the patient comorbidities and complexity. So what is their bleeding risk? Are they frail or not? What are their comorbidities? Do they have viability? And then looking at their coronary complexity, so their syntax score, and looking at the challenge from a technical point of view to us as interventional cardiologists. Is it calcified disease? Is it bifurcation disease? And then is there concomitant valve disease? So it's not just the LV dysfunction. And how likely am I to be able to insert a mechanical circulatory support device if they have peripheral vascular disease? And the next thing is institutional capabilities. Do I have a critical care protocol? Do I have surgical backup? What is the experience of the operators for these kind of procedures? But ultimately, like the patient that I showed you, when they leave the hospital, you want long-term management and follow-up. And do you have that kind of a setup? So when we talk about high-risk PCI, yes, it may start in the cath lab, but it actually extends well beyond the cath lab. And if you successfully send the patient home, you want to be talking about quality of life and rehab and optimizing medical therapy, particularly heart failure. There's this misconception that we overdo PCI and we overuse mechanical circulatory support. And we hear it and we see it all over social media. But I want us to look at the evidence, and let's look at the data. And actually, the evidence shows differently. This is from 2022 in JACC. Zhang and colleague actually showed that patients in cardiogenic shock or with systolic dysfunction, unfortunately, up to 50% of them don't get coronary evaluation. So actually, we're under-treating these patients and under-evaluating them. Again, this is one from Renato Lopez, published in Circ Interventions, where he looked at invasive versus conservative therapy in patients with LV dysfunction. Now, what I do want you to see is, this was a spin-off from the ischemia trial, but look at the dashed lines here, look at the black and look at the red. These are patients who had LV dysfunction. The black are those who had conservative therapy, i.e. they did not get revascularized, and the red are those who did get revascularization. And you do see there's a significant reduction in the primary endpoint here. Now compare it to the difference between the solid lines, i.e. the patients who had no heart failure or LV dysfunction. You do see that the gap is much wider in those who have LV dysfunction. So the benefit that may be extracted in those with LV dysfunction is certainly greater than those without. Again, moving on to this publication from Circ Intervention, it actually wanted to look at real-world data, over 200,000 patients with coronary disease, stable, so quite similar to what we saw in Revived. And they did some propensity score matching, and they looked at balloon pump as the most common mechanical circulatory support device compared with other devices. Again, ultimately, you end up seeing 0.3% underwent elective PCI with prophylactic MCS. 0.3%. So again, it emphasizes my point that we're not overusing. We're shying away, we're being critiqued, and it's good to have some introspection, but actually we're not overusing devices and we're not overusing revascularization. And they looked at in-hospital major adverse cardiovascular events and cardiovascular complications. What you do see is that with balloon pump, although there was a lower rate of complications, of course, you're looking at an 8 French sheath compared with 12 or more with ECMO, but they also had higher risk of major adverse cardiovascular events. So bear that in mind, that managing complications, bleeding, and so on is something that we should be capable of doing if we can potentially reduce major adverse cardiovascular events. Again, from the same publication. So when we look at these, we also need to look at what happened. So around 2015, when a lot of the data now, IABP shock 1 and 2, and a lot of the data was coming out, we do see that the trajectory for mechanical support devices is increasing. Balloon pump pretty much plateaued. But when we look at effectiveness of the devices. What you do see is, yes, you have less complications, 9.6 with balloon, the complication rate, the bottom one, 18.2 compared with 19.1, but actually the reduction in death, shock, and new heart failure was a lot more significant. So you're looking at 9.6 compared with 6%, as opposed to a more marginal reduction in complications. And when we look at why we're using devices, we're using mechanical circulatory devices in triple vessel disease in a small percentage of patients. The majority are for left main. So again, not very similar, just similar to the patient that I showed you. RESTORE-EF was published in the Journal of Society of Cardiovascular Angiography and Interventions. Again, real-world data looked at 2019 to 2021. So contemporary practice, they captured baseline characteristics, including EF and New York Heart Association, and this is what they looked at. They looked at PCI that was high-risk PCI supported by mechanical support, actually had a significant 76% reduction in their NYHA class. So if you look at the gray, 32%, that's about class 4. It almost disappears post-PCI. Likewise, when you look at their angina, so you're just looking at angina here. Again, the gray, 44% and 28%, looking at class 3 and 4. Once again, a significant reduction to about 2% post-PCI. They also captured an improvement in the ejection fraction, although we don't always see that. But in this particular observational data, they did see it. So I'm going to circle back to this again. When we're looking at patients who are considered high risk, what we want to do is determine the complexity of the coronary disease, look at whether they have a hemodynamic compromise. Is it just an absolute EF of 25%? We have plenty of patients walking around with an EF of 25%, but not every 25% is the same. There are those who keep coming back. So what's their EDP like? And then comorbidities, so diabetes, renal dysfunction, and so on that are additive. But ultimately, the intersection between all of these is how we decide as a heart team with our surgeons, with our heart failure experts, and so on, whether we should revascularize this patient, and if so, how. Are they surgical or not? And if not, what is our PCI strategy? Again, this is from Dangas and colleagues. This was terminated early, but what you do see is that with balloon pump compared with Impella, there was a 29% reduction in major adverse cardiovascular and cerebrovascular events. This was prematurely halted for futility because at 90 days, the primary endpoint, there was a significant reduction. And again, you see, similar to what we saw in the RESTORE-EF, that there is a significant improvement in symptomatology in these patients. So not just a survival benefit, but you also see symptoms. Well, that was the US. I showed you a lot of data from the US. It's important to look at the rest of the world. I think important data came from the Italian group that looked at the Impella registry. And I think the most important takeaway message from this particular study, at least for me, was that we finally addressed complete revascularization. And here they clearly and uncategorically showed that a significant lower occurrence of death and non-fatal myocardial infarction with more complete revascularization, which was permitted with the use of mechanical support. Multivariate analysis showed that the predictors were actually whether the patients presented with an acute coronary syndrome, i.e. non-STEMI and STEMI, and what their BCIS score was. So what do? You want to look at the overall risk of the patient as we discussed. So their surgical risk, their PCI risk, a team approach. Ultimately, you want to look at the pre-interventional risk. So how can I optimize this patient before they come to the cath lab? Renal function, for example. Do I want to make sure this patient's fluid status is at its best because that actually protects the kidneys most? Myocardial viability, yes, these are critical decisions when we're looking at patients who have, for example, CTO. If they do have a CTO, why would I jeopardize them if it's non-viable? So I think these are critical questions to answer. Concomitant disease, valve disease, and peripheral vascular disease. Have a conversation with the patient and their family about expectations. Do you expect them to survive the hospitalization? Do you expect them to have a reduction in or an improvement in quality of life, but also an improvement in survival, or yes or no? And a lot of these are gray areas that we have to be very clear about. Again, the use of mechanical support and PVADs, femoral access, alternate access, strategizing, having a plan B, and being ready for potential complications. These are patients who do not really tolerate complications easily. And again, as I mentioned, once the patient leaves the cath lab or leaves the hospital, there's more to be addressed. So antithrombotics, optimizing medical therapy for LV dysfunction, and ultimately lifestyle modification and rehabs and heart failure clinics. How do we manage these patients? This is an additional slide that I'm just going to zip through because I know I have less than a minute here. But ultimately, you want to look at the options where you want to use angioseal or perclose, vascular surgery. Explore all your options when you're looking at closing these patients and mitigating potential complications, the most common being bleeding and vascular complications. So, many patients fulfilling the criteria for high risk are not eligible for CABG, but have symptoms or an ACS presentation that warrant our intervention of some sort. Unprotected high-risk PCI leads to high procedural risk for the patients, the data I've just showed you, and MCS can help to control hemodynamics and provide time needed to do a safe but also complete revascularization. And again, a stepwise multidisciplinary strategy and planning is key for these patients. Thank you.
So thanks, Mirvat. Consider that you have the possibility to pose your question through the app, and we will see, and then we will discuss at the end of the 3 talks. So if you have any question, please post it on the app, or later on you can come to the microphone and pose your question. So the second, so thanks a lot, Mirvat, and then we will have the question at the end. And it's a pleasure for me to introduce you Giuseppe Tarantini. He will talk about breaking down cardiogenic shock and analytical reflection on the DanGer-SHOCK and ECLS-SHOCK trial.
Thank you, Laide. Good morning. So this is, as you can see by the title, an analytic reflection of the 2 main trials, DanGer-SHOCK and ECLS-SHOCK trial. This is my disclosure. So what about the background? Actually, I'm going to be very simple. We know by the S guidelines and America guidelines that we have class 3 indication for routine use of intra-aortic balloon pump. The recommendation is pretty much the same for the ECMO. By means of the American guidelines, class 3 indication, the routine use of ECMO in cardiogenic shock. On the contrary, the Impella use is supported by the guideline, American guidelines, is class 2 indication based on the reduction of 6 months mortality in patients treated with AMICs, treated with PCI, supported PCI by Impella, compared to the standard of care. So after that, I think, I would like to spend a few seconds related to this patient-level meta-analysis published last year. Here you can see the list of the trial included in this meta-analysis, and there was no overall benefits based, on the overall imputation of all the data that they include in this analysis. But actually what stands out is that there are 2 major trials. One is over 400, the other one is 355 patients with an opposite direction of the results. So I think we need to understand more if there is whether or not there is a benefit of the MCS and specifically of a given type of MCS. So we were asked from the American Journal of Cardiology to do this paper that actually is an analytical reflection where the main question is the following. The difference in the outcome in the 2 trials is related to a different strategy or is related to a different patient population? So this is the main question that I would like to share with you. So let's review together the baseline characteristics of the 2 trials. First of all, 100% of STEMI patients in DanGer, 2/3 STEMI patients in ECLS-SHOCK. Then here I listed the variables that were significantly different between the 2 trials. Actually, there were more patients with class C cardiogenic shock, and then the lactate admission was worse in terms of millimole per liter in the ECLS-SHOCK. The resuscitation before randomization was 77% against less than 22%. And actually, the MCS initiation before PCI was 84% here and only 21% here. So 2 completely different strategies. One was a preventive strategy. The other one was a bailout strategy. So 2 different animals, completely 2 different animals. But the point is that during the discussion of the meeting, the general question was that actually the results were different because in the ECLS-SHOCK, the patient population was more risky, was more sick. Is it true? Let's see together if it is true. So how we can decode the risk in randomized trial? One is to make a list, a slate of different variables that might be, let's say, tens 20, 30 sometimes, and to try to isolate the difference in terms of the final risk profile is very difficult. It's a kind of cherry-picking things. It's very difficult. Another way to sum up the real final risk profile of the patient is to look at the real mortality rate of the control arm. That means that the proxy of mortality risk is the real mortality rate in the control arm. And actually, let's see what happened when we dive deeper into the two trials. At 30 days, this is a Kaplan-Meier extraction because for the DanGer-SHOCK, we don't have this data published, but we can, by means of software, extract this data, the 30-day. And when you look at the mortality rate of the standard arm, actually it's pretty much the same. The difference is 2%. So the perceived difference in the final risk profile based on this baseline characteristic is not true in the standard arm. What happened in the treatment arm? The difference is 8%. We're not supposed to make comparison in terms of p-value and so forth, but numerically this is consistent on top of the fact that we have similar mortality rate in the control arm. Let's see what happened in 6 months. From 30 days to 6 months. Again, the difference in mortality in the standard arm is pretty much the same. Only 3%. But the difference in the treatment arm of the two arms of the two randomized trial still remain 8%. It's quite stable. Let's see what happened in a single trial, that is the DanGer-SHOCK at 30 days and at 6 months. At 30 days, the p-value is not significant, but is 7%. The difference between primary PCI overall and thrombolysis is 2%. And this is significant because we have 30,000 patients. Here we have 7% of difference. It's not significant because the numerosity is low. 300 patients, over 300 patients, not 3,000 patients. But at longer-term follow-up is 13% and is significant. P-value is below 0.04. So going back, with this in mind, to analyze this meta-analysis again. And we need to look at the subgroup analysis. And when you look at the multivariate analysis, the variables that were consistently related to the benefit of using the support are using an unloading MCS, trended 0.07, STEMI patients, and the ECLS, the two-thirds had STEMI. Systolic blood pressure remained very low, and TIMI flow, that means ineffective PCI. That is consistent. That in fact, when you have an ineffective PCI, having a support there can, be a little bit more forgiving in terms of the prognosis of the patient at the end, because you expand the window in this patient to treat this patient to be effective with other therapeutic strategy. So in conclusion, similarities, this is a very important concept. Similarities in baseline mortality risk in standard arm between the two trials indicate that what we perceive is a sicker population is not true, as based on the mortality risk of the control arm. Second point is the following. On the contrary, we cannot state the same in the invasive arm. For instance, early Impella use, preventive Impella use, 84% of the cases, enabled unloading before PCI, unlike what we have seen in the ECMO, that was a bailout strategy. It was not used before, but just in case they had a complication, or actually they decide for some reason to use after or along with the PCI and not before the PCI. Finally, in the DanGer-SHOCK, the benefit of 7% was not significant, emphasizing that the value of longer-term evaluation in patients like that with cardiogenic shock. But please remind one thing. In the guidelines, we have class 1 indication in case of cardiogenic shock for emergency revascularization based on the SHOCK trial. And the SHOCK trial 30 days was not significant because the difference was 9%, but not significant. It was significant at 6 months. Pretty much the same we can see in this trial with the DanGer-SHOCK. So in conclusion, offloading revascularization significantly reduce midterm mortality. Early use is crucial. It's a strategy. It's not just a device. This is a strategy. The DanGer-SHOCK is a strategy. It's not just Impella. Careful patient selection is essential. Excluding persistent coma post-ROC is important. Was an exclusion criteria in the DanGer-SHOCK. Patient phenotypes matter a lot. DanGer-SHOCK included just left ventricular cardiogenic shock. Thank you for your attention.
So thanks, Giuseppe. Again, we will have the discussion at the end. Pose are the question on the app or later on. And it's a pleasure for me to introduce you the last speaker, which is Basileios Panulaos from UK, 1 year post-DanGer-SHOCK, trial insight and subset analysis.
Thank you very much, Ada. So before I start, can I just see some hands up who is an interventional cardiologist that does primary PCI, quickly? Yeah, a good portion of the room. And of those that lift your hands up, can you lift your hands up if you're doing routinely echo on every single primary PCI that comes to your lab? A few less. And of those that do routinely blood gases in the patients that come to your labs? Even less. Okay, great. So I'm here to talk to you about something that probably you heard about. This was the trial that was published last year in New England. And it was important because we all know the basics, and we know that shock is bad for you, and only half of the people that come to you with shock will survive. And the question was very simple. Will a flow pump reduce the mortality at 6 months? And as Giuseppe just described, you know, people that come to us with cardiogenic shock have a lot of backgrounds. They're kind of a mixed bag. You see people with right ventricular failure alone, or mixed LV and RV, or had cardiac arrest and came back, or an ongoing cardiac arrest. So it's not a very straightforward population. And you saw that ECLS had a lot of cardiac arrest, whereas DanGer-SHOCK had only 20%. And focused on people that had good chances of neurological recovery, in fact, GCS more than 8. So it's very focused on LV failure, rather than the rest of the phenotypes of people with shock that come to your table. And the inclusion criteria were very simple. So of those that do not do echoes and do not do lactates, you will not be able to include or decide if one of your patients is a DanGer-SHOCK candidate. And the whole point of me lifting your hands up beforehand is to demonstrate to you the biggest problem in employing this trial to clinical practice is that we do not do it all the time. So if you don't do it, you're not going to see it. You think you can see it, but you can't. And we have a lot of patients that come and have lactates of 3 or 4, but you know, they have this systolic of 100, 105, 95, and you're like, they're holding, but they're not. Exclusion of danger were RV failure, comatose out of hospital cardiac arrest, and mechanical complications. So inclusions, remember, STEMI, yes, easy to discover, LV below 45, and hypotension and hypoperfusion. Hypotension was systolic under 100 or inotropes, and hypoperfusion was a lactate more than 2.5. They also had a mixed venous saturations, but I don't think anyone does that routinely. So the study design was very simple. So you would either be randomized into having a standard PCI with your whatever treatment, inotropes, vasopressors, but also at least 48 hours in your intensive care unit. And on the Impella arm, it would be the standard procedures plus Impella. And you would need at least 48 hours of Impella support. In both arms, you were allowed to escalate to ECMO, but escalating to or putting an Impella in the standard of care arm was a violation of the protocol. And we looked into all-cause mortality at 180 days. So these are the patient characteristics. You can see predominantly male, as it happens with heart attacks. Median 67 years. Quick times, median 4 hours from onset of STEMI symptoms to randomization, and that was mentioned before in the previous presentation. 84% of those randomized in the cath lab. Median lactate was 4.5, so quite high. Ejection fraction median again was 25%. And another kind of discrepancy with ECLS. In ECLS, there were a lot of people with ejection fraction over 35 and 40%, a quarter of them, in fact, that went on to ECMO. And that kind of bears my question as to why would these people need ECMO. Median systolic here, 82. And you see the culprit was mainly LAD or left main. Sky class, 55% were C. And that is based on the Navin Kapoor definition, not the original Sky, just to clarify. That was from a paper in July 22. And 45% were Sky class D or E. Revascularization, most of the patients in both arms got the culprit sorted, but you can see also a big majority of them got the non-culprit sorted. Nearly 45% in both arms. And the door-to-balloon differences were very little. For those of you that think that Impella is going to add a massive amount of time to my door-to-balloon that I'm always judged in my center. It's true that the study was performed in experienced centers, but you know, there's no reason why no one can achieve these times. Impella takes 5 minutes to set up and put in. It shouldn't take much longer, 5 to 10 minutes. In terms of crossovers, you can see that only 2% in the standard of care arm got Impella, which is great for the study because it didn't have many crossovers. I remind you, in the EABP trial, there was a 10% crossover. In the ECLS, there was a 25% crossover, a mix of devices. So it was a very big crossover. That's also impacting your results at the end. And you can see also there was a liberal use of VA ECMO, both in the Impella arm, 12%, but also in the standard of care arm, 19%. So because people arrest and die, and operators feel like we need to do something about it. So these are the main findings at 6 months. Absolute reduction of nearly 13% with a number needed to treat of 8. So you put 8 devices in, you save a life. Big number. But then we also spotted that this number is probably more prominent in younger people. And then there was this JACC publication that basically showed that younger people, patients, benefit more from the device. And if you pay close attention to the relative risk reductions, you can see there that curve that if you're in the 50s and you're 60s, you have something around 25% absolute risk reduction, which means for 4 people that you put Impella in, you can save a life. So that number needed to treat goes down even more. And as you can also see, when you're above 77, that was kind of the territorial cutoff, your benefit from the device seems to fade away. And probably that's because complications occur more often in elderly people, in specific bleeding. We all know that. The older you are, the more likely you are to bleed, whether it's your groin, whether it's your GI tract, whether it's everything. So it seems that as you get older, the potential complications outweigh the benefit of the device. But as you are younger, you get tremendous benefit. The other aspect that was interesting is that the benefit didn't seem to be as prominent in the females. But then again, the problem was not the fact that they are females, it's the fact that females generally are way more resilient than whingy men. So what they do is they stay at home sitting with their heart attacks and present much later. And we see that not only for primary PCIs or PCIs in general and MIs, but also we see that in the TAVI land, where people with ladies with aortic stenosis present to us much later stage. Same thing happens, you can see there they present older and they also come much later. What about the heart rate and the mean arterial blood pressure and generally the hemodynamics of these patients? So in a sub-analysis of the DanGer sub-study, you can see here that heart rates and blood pressures were roughly the same in the 2 groups. In fact, if you see the orange, which is the Impella arm, you can see a slightly better blood pressure, particularly in the first few hours, up to 12 hours. What about inotropes though? Because you have a dying horse. That is your heart when it comes with a massive STEMI. And when you give inotropes, you're whipping that dying horse. So if you see here, and pay some attention to this slide, standard of care is the blue column on the top, and the orange one is the microaxial pump. So focus, for example, on 3 hours and 6 hours. You can see that in the blue columns, there's a lot of red. And that means that in the standard of care arm, there was a lot of inotropes in those early hours after your heart attack, in your early couple of days, a lot of inotropes in your standard of care. So you're whipping that heart relentlessly to just maintain your cardiac output. Whereas in the Impella arm, there's a lot of blue. That means the heart was resting a bit more. And what does that mean in long terms? We will find out soon. But basically, in my mind, that means that you probably have less problems with reduced ejection fraction in the long term and less myocardial injury. You saw a faster clearance of lactate also. You saw a much lower, as expected, vasoactive inotropic score. This is for those that are not intensivists and into the shock business. It's a score that's calculated by the number of inotropes you have. You calculate your dopamine or the butamine plus your adrenaline, times 100 plus your vasopressin times 10,000, and then you calculate the score. The higher the score, the more in deep trouble you are. But as you see, with less inotropes, you achieve faster lactate clearance. But obviously, we all know that the Impella arm had slightly higher adverse events. In fact, there was more bleeding, 22% over 12%, more renal replacement therapy. These were the kind of more striking ones. And with regards to the bleeding, I think it's very clear that if you are on more devices, then you get more bleeding. If you start with nothing, you're good. If you start with Impella alone, you're a bit lower. If you have ECMO alone, you're 35%. If you do ECMO, you have very high bleeding risk. But then obviously the hazard ratios in the end don't really change because obviously the people and the physicians will sort out the bleeding. But what's impressive is Hands up, without looking at that slide of you, who thinks that the bleeding is happening whilst we are on support? Hands up. The majority of the bleeds happen on support. Like when you have the Impella in. Who thinks that the bleedings happen then? Only one person. The rest of you think no? Or you're probably asleep. Okay, for me it was an eye moment. So look at that. 50.3% of the big bleeds happened after you took out the device. What does that mean? That these people have a deranged profile, and we give them iron, we give them antiplatelets, and we give them heparins, and we give them stuff. But even when you remove the devices, they are much higher risk to bleed. So we need to do a little bit better in terms of our protocols that we use for people with mechanical support. So not all bleeds are access site that everyone thinks. Only 23% of them are access site. There's a lot of GI bleeds, 15%. Another related to other things. What about the risk of kidney injury? There was a high risk of renal replacement therapy amongst the Impella users, and that is a true fact. There is obviously the survival bias that, you know, higher risk patients survived longer and they needed renal replacement therapy or deeper shock, yes. But also the device itself, when you put it in the wrong place and it does suction events, it will hemolyze more. If you're bleeding from your groin and the device does suction alarms, it is associated with AKI and hemolysis. If you work it at a really high speed, like P6 and above, compared to P6 and below, you will have higher hemolysis. That's a fact. The reality, however, is in the long term, no one from the survivors of the DanGer-SHOCK on the Impella arm needed renal replacement therapy. So no one ended up with needing dialysis, which is good. What about this meta-analysis? You showed before that overall, this meta-analysis that Giuseppe showed you showed that there was no benefit. However, if you look closer in people that have low risk of hypoxic brain injury, actually it did provide a survival benefit. MCS did work. What about using those selection criteria from DanGer to other populations? I think we can probably deploy it in about a quarter to a fifth of STEMI and non-STEMI populations. This is what these studies are showing us. And before it was mentioned that you see shock, based on the shock trial, we all wake up in the middle of the night and go and do primary PCI because we're thinking we're really saving lives. And we're reducing that absolute mortality about 13% in 6 months. And here we have a study that shows exactly the same 13% mortality reduction in 6 months. That is the DanGer-SHOCK. And let's see, the SHOCK study gave primary PCI a 1B indication in the ESC guidelines. Now let's see what the DanGer is going to give to the ESC guidelines now. So summing up, if you use Impella on top of standard care, there's reduced death from any cause in selected patients with STEMI and cardiogenic shock. And we know that this effect is much more prominent in patients under 80 years of age. It was associated with a less need for vasopressors, and you would clear your lactate much faster. But it had this toll on the comorbidities, including increased risk of device-related bleeding, AKI, and limb ischemia. But despite those, as I mentioned, very good number need to treat. So in my view, there's some clarity that has been provided by DanGer. It's very easy for us. Now all of us can do these things. Look at your ECG like you always have done before you jump into primary. Now you can pay a bit more attention to the biochemistry and the echo, have a look at the ejection fraction, and have a look at your lactate or your mixed venous saturations. Then you can make a very quick decision. Does this patient need support? Yes, no. The problem I always have with my colleagues and whenever I'm going to teach someone is that there's always some hesitance on using the device. And I think hesitance comes from fear. If you've used this device in the high-risk PCI setting and you're comfortable with it, there's no need to fear. Whereas if you are comfortable with it, the criteria are very simple and they're there for you to see. However, has that solved all our problems? No. The answer is it hasn't. There's a lot of people with normotensive shock, with systolics, more than 100 without inotropes, but lactates that can be 3, 4. And you see these people, they are in shock, but there's no study for them yet. There will be, hopefully, in the very near future. Mechanical complications, again, we don't know. Severe RV failure or biventricular failure, we don't know. People with valvular disease, we don't know. People that are non-MIs, we don't know. So there's a lot of question marks, but at least now we have clarity for a specific subgroup. These rest of them, they are in a danger-free zone. So thank you very much for your attention. This is like a little schema of how I like to monitor my patients, be more reactive with hemodynamics, then with oxygen saturations, and lastly with lactates and tissue perfusion. If you operate on just following the lactate, you're always going to be 3 to 6 hours late. So try to be on top of your game and as ahead of the game so people don't slide. Thank you very much, and thank you to all the DanGer-SHOCK investigators.
Okay, so we have time for to answer very few of the questions. We had a lot of questions, by the way, coming. So let's start from the high-risk PCI that was the first talk, just briefly. Actually, we do have now class of recommendation according the CCS, European Society of Cardiology guidelines. Clearly, it was a level 2B with the C because we need data. So can you comment a little bit on trials that are ongoing on high-risk PCI?
Yeah, so the PROTECT series, we do have the latest one of them. I think they looked very carefully at the design compared with PROTECT 1 and 2, or I don't think they defined their endpoints well, and so it was really neutral, although they were able to deliver more complete revascularization, and I think that's what we're going to learn a lot more. So we're all really waiting primarily for the PROTECT 4 trials.
And there is also a large registry ongoing in Italy and Germany, which is called PROTECT EU, that will give us also very important data then on a real-world population. Going indeed with the cardiogenic shock, which is where indeed we have evidence with a positive trial. We had changes in the guidelines from US. Let's see what happened then in Europe. Also because they give a class 2 recommendation saying that despite the trial was positive, there were the issue of the vascular complication. And by the way, Vas, you explained quite well where it encountered. But that's interesting. So going to Giuseppe first and then to Vas, we have to really be in 4 minutes. So first is you, because I'm following the order of the presentation on SLS-SHOCK, because there was a question regarding, you were mentioning these, maybe the patient on one side were severe, but there was a 50% on cardiogenic shock C. So can you comment on that? Because that was a question coming.
The point is, I think that the scale definition is very academic. When we say BC, you are C one time, you are D the 2 minutes later, and then you see again 2 minutes later, two further minutes later. So the point is that we don't need to stick too much to this. What I think is important for cardiogenic shock is not just to consider door to balloon, but also door to unloading. I think is very important because just to do the math, when you have 80 millimeter of mercury in the aorta, or 90, let's say that is refractory, based on the fact that with the inotropes, you don't have any contractile reserve, because it is many times like that, especially when you have a little bit of acidosis, things like that. When the end-diastolic pressure are 35, 80 minus 35 is 55. So you are out of the autoregulation curve. So you're ischemic even without stenosis. So that is the point. So this is the reason why to increase the perfusion pressure when the blood pressure cannot be increased, because also with ECMO sometimes you cannot increase the blood pressure. The only way to go is to unload the system and to change this difference in the blood pressure between the aorta and the diastolic blood pressure, that is the perfusion pressure of the heart. Agree with that?
Yeah, 100%. We're always a bit late, and I think that's an important point. Go in early, basically.
Yeah, and then there is an escalation of the class of shock. I mean, there were studies demonstrating they come in B and then they arrive in D, so it's very complicated.
So really. One quick question for him. So the only thing is that sometimes we think that the increase in renal failure is related to the hemolysis, but what I think is sometimes we need to be balanced, because if we pursue at all costs the complete revascularization, anatomical complete revascularization, that sometimes is not needed, because we need sometimes a reasonable incomplete anatomic revascularization. We don't have to finish up with 300 cc of contrast. This is the reason why sometimes we have ACI, because we try to do all what we can do that is not needed to do. So it's not just hemolysis, I think, but also you need to make the trade-off with the time of the procedure. It is always a surrogate of complication in any case. I don't know what you think.
Absolutely, and you have always the time to do the stage PCI in the same admission a bit later down the line. There's no harm. So yeah, absolutely correct.
So the last question, but very short, there was mentioned something that is ongoing a lot regarding the centers. So there was a center effect in the DanGer-SHOCK, how it comes, because we know that actually Danish center were in a way, and German center indeed had other outcomes. I don't know, by the way, about UK, because you were the center. So can you comment on that? Because that was a question coming. And then we close.
So there was no different statistical for interaction for those that keep pursuing that. Overall, the trend was the same anyway. So, and yes, what that shows is that shock is not just the cath lab operators. And I think that has to stick in the mind of everyone. It's a team game. And if you have one weak link in your team, then the whole domino is going down. So you could be the best primary PCI operator that saves your patients an amazing result. If someone in ITU does a bad job or they omit a complication, that's it. Your patient is dead. So I think one point for all of you to come out of here is that don't concentrate just on yourself or your cath labs or your kind of interventional cardiology colleagues. Build a very strong team relation with your vascular surgeons, your anesthetists, your cardiothoracic surgeons, everyone in the hospital, your nurses, because they are the key players to look after these people. If you don't have a strong team, you're never going to have good outcomes. We learn it the hard way, and we're still learning it the hard way. We're still doing mistakes, but we just make sure we learn from those mistakes.
And I think this is a nice way to close this session, because clearly this is a shock team effort. This is, if you are treating patient with cardiogenic shock, it's such a complex disease and pathology that you need a multidisciplinary approach. And you need really to have trained not only interventional cardiologists, but all your team. And I can sum up, by the way, saying that within the European Society of Cardiology, we did create a track for cardiogenic shock. It will be called School of Shock, by the way, of cardiogenic shock. The first will be in Paris, 8 and 9 of September, and this will be together with ACVS, so it's interventional together with intensivists, and the second will be in January in Spain. So that's the point. We have positive trial, but now we have to go into education of local teams. So thanks for your attention.